Testing, 1, 2, testing. One, two, testing. Dr. Sharma, how you doing?
I'm
Yeah, good
doing
evening.
fine. Good evening, Anil.
You
I
look
was,
like the moderator.
Yeah.
Hey, you want to put a background on your screen there? You know how to put a background on?
yeah, that
I
I can
couldn't
start.
get.
Yeah, put a
I,
The voice is
background
not
on.
very.
Yeah, put a background on if you can. Make it look professional. You know how to
there's,
do that, right?
I cannot see my video. This.
Yeah, go to the video icon at the bottom and it'll say adjust background. Yeah,
It's
adjust background. Click on that and will allow you to look around your computer to find your background.
no, it's not showing any video option. No?
Yeah, you see the video camera at the bottom of your screen? And next to that's a menu. Open up the menu.
I'll join again. I think I don't know. Means I'm not seeing
Yeah,
here.
open up the
Yeah,
menu and
I'm not seeing anything.
हेलो आदेश।
Hi, Dr. Raman.
हाँ, कैसा भाई?
बढ़िया बढ़िया.
How are you doing?
okay, Anil,
It's
we're
not
waiting for Anil to
connecting.
come in.
Zoom registration of this link. List.
Yeah, now it's seen. Now it's seen.
There's a Dr. Sharma. How you doing, Dr. Sharma?
Yeah, I'm
Doing
fine.
fine, sir.
Are you ready? Okay, your
Yeah,
background, your background's not resolving well. You're gonna have to change that. You can see it, right? It doesn't look too good.
Okay, not very clear.
Yeah,
So how are you? How are you, John?
good. Try to get the background right. Get a different background. You pick a few different few.
I'll try to do it.
You click on. Okay, let me take you through it. You go to open the icon, the menu next to the video camera. You see at the bottom of the screen on Zoom, you see a video camera. Do you see
Right.
that? You see that, Raman?
Yes, I can see.
Okay, next to that camera is a menu. Open up the menu. And it says adjust background and effect. Click on that. And then look around your computer for a background. Or you can do what Dr. Sharma did. He just blurred his background. You can figure it out later. You see the blur of your background?
Yeah. I don't want any background right now. I am in a
Okay,
at my
don't worry about it. Don't
in
worry
a.
about it.
Okay,
It's no big deal.
actually, I'm on a vacation, so I'm somewhere else.
Yeah, I know when you travel, it's different.
Yes.
Everything gets screwed up.
So how are you doing, Anil?
Yeah, I'm good.
Okay, Anil,
Yeah, can I start?
people will come, but a lot of people watch it on YouTube now. They don't come into the panel. They watch it on YouTube on Neurosurgical
Okay.
TV. But they'll come. Well, they'll be coming in.
So you just let me know when to start. I think we can start.
Yeah. What I'm going to do, Dr. Raman Sharma, is talk about the show and then introduce you. Dr. Sharma is going to moderate and you introduce Anil. Okay?
Okay.
I'm still not
So,
getting an option to switch on my video. It's only showing the audio bar.
I see, Dash, you need to turn on your camera. You see the
But there
bottom
is no
there?
option
You see the bottom of your Zoom screen is a camera. You need to turn it on.
No, there is no camera there.
Okay, are you on a
I don't know.
smartphone or are you on a,
No, I'm on a MacBook.
okay, do you have the video option at the bottom? Is there a camera?
No, it's not showing. Only the audio is showing.
What happened to your last Zoom? What'd you do in your last Zoom?
Yeah, I did a video in Moa Zoom.
Oh, okay. Well, just do the same thing you did. To get the camera on. Good day, Ramesh
अनिल
Tigala.
तूने
Yeah, good day,
कैमरा
John. How are
कैसे
you
ऑन
doing?
किया
No,
था?
I have nothing to do with it. You've got to get your own camera on. You got to turn it on.
No, you just
John, good evening. Seeing you
Oh,
after a long time.
Maybe, that's true. Maybe you're not
Yes,
in the panel. Okay, let me
option
see
you
if
can
you're
go
in the
and-
panel. Hold on. Dash. Oh, you're right. Okay, I haven't promoted you, Dash. You're right.
Yes.
Okay, now that you're in there, Dash, you should have that option. Do you see the option now?
Yeah.
You
Yes.
see the option
And
now?
now you can see me as well.
Good. Okay, Anil, you have to get off the screen. Get off the screen share because I want people to see your face.
No, shall I stop
Anil,
sharing?
screen share band pe.
No,
Okay.
Stop sharing.
You stop sharing.
Yeah, I'm done,
I
I'm
want to introduce your face so people get to know you. Okay.
Yeah.
We'll have a lot more people by the time you get going. Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2. Good morning from Miami Beach. This is Dr. Bennett. Here we are, right over here, the home of Neurosurgical TV. We have the honor of having a grand rounds of the AIIMS in Raipur Hospital. I always envisioned doing a webcast from AIIMS. I read a little about the history, how it's a chain of hospitals, about 11 different AIIMS hospitals, and I'd really love to get that community together. At any rate, let me introduce the moderator for this session, Dr. Raman Sharma. He's going to introduce the other Dr. Sharma. Welcome, Raman.
Thank you so much, John. Thank you. A very welcome to all of you to the channel. And as we know, I welcome you all to this very good discussion on endoscopic surgery. Now, endoscoping is pushing the boundaries, and it has been advancing day by day with the latest instruments and interdisciplinary uh, involvement and ever expanding precision of the endoscopes. Now we are doing endoscopic surgeries in spine as well as a skull base. So today I welcome you all, and today the speaker for today's session is Dr. Anil Sharma. He's one of the very good friend of mine, and he has been into the skull base surgeries for a long time and has an experience in training as well as doing a lot of skull base surgery. So he'll be today speaking on the topic of extended endoscopic surgeries. And I welcome Dr. Adesh Srivastav from AIIMS Bhopal, and one of a very known neurosurgeon in India. And along with Dr. Ramesh Tigla from Vijayawada,
Yes.
he has been one of the pioneer neurosurgeons in India. So I would like now request Dr. Anil Sharma to start the talk.
My screen is visible.
Yeah, I think it's visible now.
Yes.
Yeah, at the outset, I would like to thank and congratulate Mr. John for creating this wonderful platform. I also would like to express my gratitude to the panelists and moderator Dr. Raman Mohan Sharma, Dr. Adesh Srivastava, and Dr. Ramesh Tigala. So today we'll be discussing about expanding horizons of endoscopic skull-based surgeries. So as we all know, this endoscopic skull-based surgery has really evolved in past 2 decades. Initially, it was started for pituitary adenoma surgery, and later on, in this current era, all the lesions anterior to foramen magnum are accessible by the endoscopic skull-based surgery. And this has become true due to refinement in the surgical technique, development and advancement in the instrumentation, development in the neuroendoscope, development in the neuronavigation, and so forth. So neuroendoscopy, by virtue of itself, bring advantages of it by looking in the corners and looking in the hidden areas. So that are the advantages, and panoramic view, a 360-degree panoramic view, that are the main advantages of endoscopes. So region which we can access by the endoscopic skull-based surgeries are olfactory tract, plenum sphenoidal, sella, clivus, and cervico-occipital junction. So before coming to detail, I would like to a brief review and brief depiction of the anatomy. So this is the cadaveric dissection image from our own cadaveric dissections. Here we can see this is the basic anatomy that is very useful, and we all should be aware about this before venturing into endoscopic skull-based surgery. So here we can see plenum anteriorly, medial opticocarotid recess, lateral opticocarotid recess, optic protuberance, carotid protuberance, sella, and clival recess, and carotid bulge bilaterally that we can see. So this is the basic anatomy, basic view that we come across after posterior sphenoidotomy and septectomy. And this is the view we get after removal of the bone. This is the optic canal we can see. We can see clinoidal carotid, sella dura, plenum dura, limbus, and clival recess. Here we have taken liberty of cadaveric dissection. We need not to dissect lateral to medial opticocarotid recess. And this is the view we get after removal of the, this is the view of anatomy we get after removal of the like meningiomas and craniopharyngiomas and so on and so forth. Gyrus rectus, acromiocea complex, optic nerve, chiasm, plenum sphenoidal, and pituitary gland, and bilateral carotid, and pituitary stalk that we can see. So this is the again cadaveric anatomy and intraoperative depiction of the same image. So coming to preoperative planning, so we need to know certain facts about preoperating planning. We need to read MRI images in the detail. We need to know about deviated nasal septum, anatomy of paranasal sinus, anatomy of sella. We all know there are 3 types of sella: pre-sella, sella, and conchal type. Conchal type and pre-sella type, it's difficult. That anatomy is not very clear, and anatomy is obscure. So it becomes very difficult. But we need to drill that concha and conchar sella, and we need to know about tumor and its extension, how much it's extending lateral to optic and carotid corridor. So coming to one important point to sphenoid septa. These sphenoid septa are often off midline, and when they are off midline, they often lead to internal carotid artery. So we need to be aware about off midline sphenoid septa, because to bring that anatomical detail clear, we need to remove a sphenoid septa. So we have to be very clear while drilling, because it often lead to internal carotid artery when they are off midline. So this is a very important fact that we need to keep in mind. So coming to, we'll see representative cases from various pathologies that can be addressed by endoscopic skull-based approaches. So coming to pituitary adenoma, that is the most common indication. This is the one of the common tumor, intracranial tumor, almost 10 to 15% of the all intracranial tumor, and third most common primary intracranial tumor. And this has been reported that significantly higher rate of overall visual improvement after endoscopic resection, and visual improvement and improvement in the postoperative endocrinopathies. So this one we can see pituitary apoplexy, lesion is extending up to third ventricle and coming into sphenoid, and we can see lateral extension. These are the post-operative images, and these are the intraoperative view. After, we can see that owl-eye appearance of sphenoid ostia bilateral, and this is the view we get after removal of the tumor, that bulging of the diaphragma sella, that completes our that reflect that our resection has been complete. So coming to surgical video, this is the image after generous posterior septectomy and sphenoidectomy. We can see bulge as it was very clear in the preoperative radiology, that tumor was bulging in the sphenoid. So here dura is being opened from lateral to medial. We need to take care of this, because while going from medial to lateral, we can inadvertently injure internal carotid artery. So dura should be opened lateral to medial. It can be opened in either ways, cross, circular, and T-shape. There are a variety of ways to. But while removing tumor, we need to respect the certain aspect. First, tumor has to be removed inferiorly, then laterally, and then superiorly, to avoid the premature descent of the diaphragma sella. Because if there is premature descent, it will bulge prematurely, and it will obviate our complete resection, and there are increased risk of CSF leakage. So first, tumor is being removed laterally, and then inferiorly, and then laterally, and later on only anteriorly and superiorly. So here we can see that there is diaphragma, the arachnoid bulge we can see. So when tumor is small, that can be resected, extracapsular dissection that can be done, but in large tumor that may not be possible. First, we need to decompress the tumor, and then we can go extracapsularly. So 360, this 30-degree endoscope is also very useful at the end to ensure that complete resection has been done. So here we are evaluating with the 30-degree endoscope, and that repair is being done. This another case, one giant pituitary adenoma extending again to sphenoid and laterally, and the tumor has been resected, post-operative images. This one, recurrent pituitary adenoma, first operated at outside. In such large tumor, this tumor was approached by combined endoscopic and transcranial anterior intrahemispheric approach, because such large tumor that may not be possible to remove by single approach. This again one tumor. So we need to know the anatomy. This cellular floor is often quite thin in the giant pituitary cases, and that would just with the help of the 1 mm Carrison or Rosen elevator, it will come. So we can see medial opticocarotid recess. Our medial, that bony resection, that has to be from medial opticocarotid recess to medial opticocarotid recess. And extended pituitary, we need to just from superior and inferior intercavernous sinus. That is the part that we have to remove, and that serve our purpose. It is. I'm talking about extended pituitary macroadenomas. So that extracapsular dissection is being done that we were talking about. After initial decompression, here tumor is being dissected. That same principle, first inferiorly, laterally, posteriorly, and then last antero-superiorly. That extracapsular dissection is being done again, and tumor is being decompressed, and that shows that our resection is complete. That this descent of diaphragma sella. These are the we can see a significant improvement in the vision and visual field. We can see in the preoperative and at follow perimetry visual field. This picture depicts how dura is being opened. This another case, tumor was extending up to third ventricle, and the tumor has been resected. But one peculiar finding in this case was cystic attachment, and this patient had hemiparesis also, which improved over a period of time. This is another case. So that we need to know that one size does not fit all. This is just to show the complete spectrum. This one 67-year-old gentleman who presented with vision loss, right eye was 5 by 60, left eye was 6 by 36. And we can see the tumor is extending unilaterally. So these kind of cases are very difficult to operate by endoscopic because that our visualization, that line of axis will not be in that single plane. So these kind of tumor are very difficult to operate by endoscopic approach. You can see how there is significant unilateral extension. So this, again, the question is about surgical approach. I decided by this tumor by standard terminal craniotomy, and tumor was resected almost completely. There is a small residual in the sella, and his vision improved significantly in the post-operative period. So this is just to complete the spectrum, and we need to know how to decide approach. But this is majority of the pituitary adenomas that can be tackled by the endoscopic approach. So coming to craniopharyngioma, this approach was initially reserved for the lesion with the cystic component with minimal supradiaphragmatic extension. And the advantage in endoscopic approach, this eliminates the need for brain detection and minimize the manipulation of neurovascular structures. For infrachiasmatic midline tumor, this provides direct access to the tumor and direct caudal to cranial surgical corridor. This led to superior visual outcome, lower rate of DI, and lower recurrence rate. This is the new classification system because the older classification system that does not hold true for the endoscope, because our reference of point in the endoscopic, our reference of point become infundibulum. So these tumors are defined in relation to the infundibulum, type 1, type 2, and type 3. Type 4 are purely third intraventricular tumor. And in my opinion, these tumors should not be approached by the purely endoscopic nasal approach. So this one 13-year-old female presented with vision loss, right side by 6 by 60, left by 1 by feet. Post-operative, she made remarkable recovery in the vision. We can see this again one very rare occurrence because tumor is extending in the sphenoid significantly. We can see. So these tumors are ideal candidate for the endoscopic endonasal approach. We need to know that for all craniopharyngioma, endoscopy is not the solution. But these tumor, when tumor is extending significantly in the sphenoid, we can see post-operative image how tumor is extending. This is CT image, and these are the post-operative image. There is small residue for which radiotherapy was given, and she is in follow-up and doing wonderful. These are the pre-operative and post-operative images. This again one case with cystic craniopharyngioma extending into sella. There is cellar widening. The same principle, generous posterior septectomy by sphenoidectomy. We need to do sphenoidectomy because it will avoid that clouding of our instrument. The cellar floor is being, after drilling, cellar floor is being opened. The principle of whether endoscopic or microscopic craniopharyngioma, principle remains same, that decompression and then extra capsular dissection. As this tumor was predominantly cystic, first cyst was decompressed, and then extra capsular dissection of the tumor is being done. And we need to give gentle traction. We should not pull, but we can give gentle traction to help in our dissection and delivering of the capsule. So capsule is being dissected. This we can see at the end of our resection. Third ventricle, we can see, and we can identify the third nerve and PCA and basilar artery at the end of our resection. So coming to meningiomas. So for meningiomas, what we do by endoscopic approach, we convert a skull-based meningioma to a convexity meningioma. How we deal in convexity meningioma? We address the first we address the bone, then dura, and then we reach to the tumor. By the time in convexity meningioma, by standard transcranial approach, by the time we reach the convexity meningiomas tumor is already devascularized. So same principles are being followed when we operate these cases by the endoscopic approach. We address the dura and then we reach the tumor. By the time we are reaching the tumor is already devascularized. But again, that risk of CSF leak, this comes at the cost with the risk of CSF leak. because these tumor are this arachnoidal tumor. Arachnoid is almost invariably will be opened, particularly when tumor is large. But for indication, for my indication for these cases, when tumor, there is medial optic canal invasion and tumor is significantly extending into the sella and there is retrochiasmal extension, these are my candidate for the endoscopic skull base approaches. And when there is not lateral extension, lateral to the, it's not encasing the neurovascular structures. So this is the case. We can see preoperative and postoperative images. Again, the surgical video, we can see spinoida ostia, the gyrus posterior subtectomy has been done. That bone drilling, in contrast to the giant pituitary, bone can be quite thick and hyperostotic in the meningioma cases. So we need to drill that bone. And the lateral horizontal extension is from medial OCR to medial OCR, and that sagittal plane, it is dictated by the extension of the tumor, but in generally, in the case of plenum or tuberculum cella meningiomas, it's posterior to anterior ethmoidal artery. And depending on the involvement of the extent of the tumor, we can remove the bone. So here we can see the tumor is being dissected from the AIIMS complex. That arachnoid sharp dissection is the key in these kind of cases. We should avoid pulling or the tempting to remove the tumor, or by pulling the tumor, we should avoid the temptation. And sharp dissection is the key in these kind of cases. So we can see how tumor is gently being dissected from the AIIMS complex. We can see bilateral A1, bilateral A2, and bilateral recurrent artery of Funda and gyrus rectus. So tumor is being dissected sharply. So what is the advantage this endoscope in these kind of cases, give panoramic view? There is minimal manipulation of the neurovascular structure, because the only structure that lies between the surgeon and the critical neurovascular structure is the tumor. So here we can see how optic nerve was severely compressed and that tumor has been dissected completely. So visual outcome by this endoscopic approach in these kind of tumors is superior, because there is minimal manipulation of the neurovascular structures. This is another case. I'll just go there. We can see opticocarotid recess to opticocarotid recess. The cellular floor is being drilled. We can identify the dura, that tumor comes into view. This is the main advantage we were talking about, that after tumor is already devascularized, there is no bleeding at all. We can see, we can appreciate that there is no bleeding because tumor already has been devascularized. So now tumor is being dissected from the AIIMS complex. Again, the sharp dissection is being done. We can see the bilateral optic nerve, bilateral A1 and bilateral A2 complex. Now repair is being done. Another case. So coming to another entity, that epidermoid, these are very rare tumor, suprasellar epidermoid, but when there is extension into the sella, this approach is useful. But for purely suprasellar lesion, when there is no extension into the sella, other approach like supraorbital or standard transcranial and transternal approach, that can be done. But cellular floor is being drilled, dura is being opened. So these are avascular tumor. There is not much bleeding while dissection, but these can be sometimes these can be quite adherent to the neurovascular structures. So we have to be very careful while dissecting these tumors. And when these tumors are significantly adherent to the critical vascular or optic nerve, some part, there is no harm in leaving some part behind. So this is the end of the resection. We get the view how bilateral optic nerve, pituitary stalk, pituitary gland, and bilateral A1, A2 complex, bilateral ICA, all we can appreciate. So this is the view we get after resection of the tumor. Rathke cleft cyst is another entity that can be done. So this is the esthesioneuroblastoma. So esthesioneurobllastomas are very rare tumor. These tumors are very rare, arise from superior aspect of the nasal cavity, from the olfactory neuroepithelium. And purely endoscopic approach is little difficult for these kind of large tumors. But these tumors can be resected. But as this entity, I mentioned, this entity is very rare, and a very less number of patients has been treated by this way. So it's very difficult to comment on the long-term outcome. So this was operated by purely endoscopic endonasal approach, and tumor was almost resected completely. We can appreciate in the post-operative images. There is no obvious lesion in the contrast MRI, the contrast CT scan. So this one interesting case. This patient presented with intractable headache for almost many months duration. This was seen by our multidisciplinary team, by our ENT head and neck surgery team, our endocrinologist. We tried a lot conservative management, but patient did not improve, and he kept coming. He's a nursing officer. He kept coming, and there is severe headache, and I'm not getting any relief. So almost after one year follow up, when he did not improve, we decided to this sphenoid fibrous dysplasia, and we can appreciate the preoperative imaging and the postoperative imaging. Navigation is very helpful in these kind of cases, and immediate postoperatively he got significant symptomatic relief in the headache. So giant cell tumor, that is one entity. These tumor are very is notorious for recurrence, and he presented with vision loss. There is significant large tumor. We can appreciate in the sagittal images how bone has been destroyed. There is the destruction of the sella and the plenum part. So this tumor was resected, and we can see the preoperative and postoperative MRI images. Inflammatory pathology, this is very rare. This isolated clivus involvement in the tuberculosis is very rare, and very few cases has been reported in the literature. So this mainly we did biopsy, and we were not very sure preoperatively about the diagnosis, and she presented with diplopia. So we did biopsy and intraoperative assessment, and that we came to know about tuberculosis. And this is the post-operatively on ATT treatment, anti-tuberculosis treatment, her vision improved, the double vision improved, and there was complete resolution of the disease in the follow-up scans. This clival chordoma, again, this 23-year-old female presented with double vision, diplopia. So majority of these clival chordomas are extradural, but sometimes they can be, when large enough, they can be intradural also. This was predominantly extradural lesion, and post-operative images, we can see there is complete resection of the tumor. So this is another one rare case, C2 aneurysmal bone cyst, that what this transoral endoscopic approach, C2, this resection was done, and then later on posterior fixation in the same setting, C1 and C2 fixation was, C1 and C3 fixation was done. So coming to intracorneal orbital tumors. So tumor which are located medial to optic nerve, and posterior, and when there is synchronous or that pathology, some paranasal sinus tumor that is extending to the orbit, these tumors are ideal candidate for the endoscopic approach. When tumor lateral to optic nerve, it's difficult to dissect, and in my opinion, should not be approached by the purely endoscopic approach. So here we can see this is one cavernoma, cavernous malformation. We can appreciate in the MRI image, optic nerve is lateral to the cavernous malformation. And again, we can see in the sagittal image, lesion is medially placed. And this tumor we approached by the endoscopic approach, and tumor was resected completely. So standard approaches for these tumor are almost same, except that we need to do enterostomy, and we need to do maxillary enterostomy. After maxillary unilateral, most of the time, majority of the time, that unilateral sphenoidotomy is enough. We need not to go to opposite side. And this is medial rectus, that orbital fascia that should be incised posterior to anterior and in parallel to the fiber of the medial rectus. So this is that we can see that this is the medial rectus muscle that is retracted with the help of the elevator, and we can appreciate the tumor. So these tumors are discrete tumor, well-defined tumor, and we can go all around and we can dissect the tumor, we can coagulate, that will shrink the volume and it becomes easier to dissect all around the tumor after sinking of the tumor. So here tumor is being coagulated and being dissected all around, and that again sharp dissection is being done, and that tumor, these kind of tumor are relatively easier to operate upon. And here we can see at the end medial rectus muscle. Sometimes that bulge of orbital fat that can be troublesome, but that can be tackled with the help of bipolar coagulation. So this repair is being done. This one hydrated cyst, again that medial to optic nerve and posteriorly placed, that was done. This JNA, we operate these kind of cases with our ENT and head and neck team. We have a wonderful ENT and head and neck team. Whenever required, we both sit together and decide about the approach and discuss about further management. So this one complication, the one rare complication that we encountered and was published. This one was giant pituitary that was operated, and on third post-operative day, patient had CSF leak. Nowadays, we prefer whenever there is CSF leak in immediate post-operative period, we prefer to re-explore and repair the defect. But it was done very long back, and on third post-operative day, patient had visual deterioration. CSF leak for that lumbar drain was put, and then he had visual deterioration. He became almost blind, and then immediately we did CT scan, and we found there was large tension pneumatocele that can happen very rarely when there is one-way valve-like mechanism. So immediately we re-explored the patient. Intraoperatively, we took assistance of the image intensifier, CRM images, to know the status of the pneumatocele. So these are the immediate post-operative that pneumatocele has come down and patient made wonderful recovery. So these complications we need to keep in mind. They rarely can happen. Again, I'm stressing on one size does not fit all. So that case we have discussed already. So coming to meningiomas. So as I said, my indications for endoscopic approach for meningiomas, when there is medial optic canal invasion, significant retrochiasmal extension, there is tumor significantly extending into the sella. So these are my indication for plenum sphenoidal or tuberculum sella meningiomas or olfactory meningiomas. So this patient presented with headache and vision loss, headache and only headache, the vision was normal. So we can see tumor is primarily centered on the plenum sphenoidal. There is no extension to the sella, or there is no medial optic canal invasion. There was no vision loss. And we can appreciate how tumor is unilaterally, extending unilaterally. So this tumor we approached by supraorbital keyhole approach, and this patient made wonderful recovery. So these are the images. I will not go into detail of the videos. So this picture depicts variety of the tumor. That first scan is that we discussed supraorbital unilaterally extending. Second, with medial optic canal invasion that we operated by extended endonasal approach. And second is very large tumor that we did by frontal craniotomy. And these lesions can be done by standard tenonal craniotomy also. But supraorbital keyhole is very difficult for these kind of very large tumors. So supraorbital keyhole and endoscopic endonasal, they have certain advantages or disadvantages. In endoscopic endonasal approach, we can do early devascularize the tumor. There is less manipulation. We get the panoramic view. We have the feasibility to look around the corners. And when there is medial, the medial optic canal invasion, so we can better visualize the medial optic canal. And there is theoretical advantage of removal of the bone and all the involved structures, which is not there in the supraorbital or transcranial approaches. But this has not been proved in the literature. So my message is careful assessment and planning is very important. We need to take into account the extent of the tumor, experience of the surgeon, how far tumor is extending in the lateral corridor, in the sagittal corridor. Proper patient selection is the key to achieve the best possible outcomes. And obviously there is risk of CSF leakage. So robust dural reconstruction is very paramount. And with the development and advancement in the pedicle vascularized Hadad flap, that rate of CSF leak has dramatically come down. So still that endoscopic skull-base surgery, the limits of endoscopic skull-base surgery are being defined. And this started from the standard pituitary adenomas, and in current era, almost all lesions anterior to foramen magnum, all lesions are accessible to the endoscopic skull-base surgery. And I'm sure with the development and refinement and in the instrumentation and visualization and all those techniques, that further improvement will occur over a period of time. This is our another article over the cadaveric study. Thank you. Thank you very much for the kind attention.
Thank you, Dr. Anil, for the wonderful talk. And you have elaborately shown the lesions, especially the anterior skull-base lesions, transnasal approaches. So just the panel is open for discussion. I would just like to ask you, down there is recently there has been a lot of talk regarding the quality of nasal outcome in such patients. So what are your thoughts, and how do you how much Hadad is to be taken, and what are the approaches which can be used to prevent any poor quality in the nasal outcome in such patients? Because as you see, after some time, patients started complaining of nasal stuffiness. So what are your thoughts on it?
Look, in these the endoscopic skull-base surgery, preservation of nasal mucosa, that is very paramount. And as far as Hadad flap, that pedicle vascularized flap, that is considered. So it's not required in all the cases. So like whenever there is a CSF leak, that large large arachnoid defect, and when there is entry into the ventricle or cistern, then only we take the Hadad flap. For standard pituitaries, when there is no CSF leak, we can avoid the Hadad flap. That is standard our dural reconstruction techniques, that is more than sufficient. But preservation of nasal mucosa, that is very important.
Dr. Adesh, any words over it?
Yeah, so at our center in AIIMS Bhopal, we have been very strong advocates of preservation of the nasal mucosa. We strongly believe that the nasal anatomy, the anatomy of the turbinates, the septum, they all play a very important role. And every attempt should be made by the operating surgeon that we maintain the sanctity of the nasal mucosa, the sinuses, the turbinates, and for that matter, the overall nasal anatomy. We try to reflect the flaps, mobilize the turbinates rather than resecting them out, and at the end of the surgery, replacing them into their natural position. So that's what we aim at. And as far as evidence is concerned, I think we are never gonna have a consensus on this, because there's equal amount of evidence in favor and against the morbidity created by the transnasal route in the literature. You have equal number of systematic reviews as well as some RCTs as well, which say go the either way. So the most important thing is one should try to preserve as much as normal anatomy as possible. Now, one more comment, Dr. Sharma. First of all, I would like to congratulate you. An amazing series. I mean, you covered everything. Nothing was left right from the anterior cranial fossa. You went up down to C2, and that's amazing. I mean, many congratulations to you for such a wonderful work that you have been doing. My observations regarding the anterior cranial fossa meningiomas. I don't know how many of you would have felt, but I often feel that when you open the brain, either you go transsphenoidal or you go transcranial, the meningioma, what you find intraoperatively, is always bigger than what you had seen in your imaging. The dural tail may stop at a point, but you may still find hypervascular and frond-like small structures on the dura. So we have recently started the trend towards going back to transcranial routes for most of these lesions to offer a more complete resection. Obviously, transnasal is a very attractive option, but in view of the fact that it's always much more than what you see on radiology, and to achieve at least, if not Simpson, better Simpson grade excision, at least to burn out that dura, we prefer going transcranially these days. So anyway, these are my observations, and congratulations once again, Dr. Sharma.
No, as I discussed in the talk also, my indications also have come down for the endoscopic endonasal approach. So nowadays, I only do when there is significant medial optic canal invasion, because in my opinion, transcranial approach, when there is significant medial optic canal invasion, transcranial approach is inferior to the endoscopic endonasal approach.
Correct.
So now I operate endoscopic endonasal approach only when there is significant medial optic canal invasion, there is involvement of the sella and significant retrochiasmal extension. So as we discussed, like standard olfactory groove meningiomas or plenum sphenoidal meningiomas, when there is no invasion, these tumor can be resected by the supraorbital or standard transcranial approaches.
Just to take the discussion forward, I would just like to ask, what are your opinion regarding the keyhole endoscopic assisted approach? I think Dr. Ramesh Tegla wants to say something. Sir, you are more welcome.
No, sir. Thank you. Thank you very much for giving me this opportunity. I really congratulate Anil for bringing up such a vast spectrum of cases, and in a nutshell, he covered everything which is possible, just like a book of extended endoscopic approaches using transnasal corridor. Anil, for the sake of listeners, I would like to bring to 3 or 4 cardinal features of approaching through the transnasal corridor. One could be enhanced. Basically, when you use an endoscope, it means that it enhances the visibility. Like visualization will be much better. You can go to the close to the target, as close to the target as possible. So regarding the enhanced visualization and navigation, so I'd like to ask 2 questions on that. Do you ever feel like 3D better over 2D, or 2D is good enough? That's one question. Regarding the navigation, what are the pre-op or intra-op navigation tools or techniques what you're using? So I'll take one after the other, so you can, I know that you'll be using and you'll be mastered in all those things, but the sake of participants and delegates across the globe, these are some basic things or most established techniques for taking any case through the transnasal corridor. In the matter of fact, any skull-based approaches, these are the very much concerned. So you can explain one after the other. So what are the concerns about 2D over 3D or other visualization tools used?
So when there was transition from microscopic to endoscopic approaches, so at that time there was a saying, like, with microscopic approaches we tend to under resect, and with endoscope we tend to over resect. Visualizer is no doubt is far superior than microscope. Visualization is far superior. Feasibility to look around the corners, feasibility to look around the hidden areas, and panoramic view, that excellent panoramic view. So that is no doubt, that is quite far surpassed by with the microscopic approaches. But that 2D and 3D thing, that with over a period of time and with experience, like it become quite used to with the endoscope. It become quite used to with endoscope. So initially it can be troublesome to use endoscope, because that 2D and that 3D perception what we used to get with microscope, that may not be there. And like we are reaching with endoscope, and we can suddenly jump on some important neurovascular structures, but with over period of time that tends to come down.
Okay, very good. Next will be like, what are your navigation techniques you follow in taking up these cases? especially the cell-based transcendental approaches?
Yeah,
Preoperative, intraoperative.
navigation is quite helpful, particularly for re-exploration cases. That is must. For re-exploration cases, I will recommend not to operate without navigation. But for standard pituitary, if navigation is available, that's that's fantastic. We can evaluate the structures, we can identify the critical landmarks. But in the standard pituitary, like pituitary macroadenomas, almost most of the time landmarks are already visible, unless it's concal and precellular type of where landmarks are not quite obvious. That time it may become difficult without navigation. But navigation is certainly helpful in many of the cases. Re-exploration and extended approach, we can, while drilling bone, we can identify the extent of the tumor. So like tuberculum cella with, so we can identify like how much bone we have to reset. We can delineate the extent of the tumor. And like as we
Yeah, what is your take on intraoperative fluorescein angiogram? Because nowadays a lot of studies and many people are using mainly to check the vascularity of the flap at the end of your procedure. And maybe extent of the tumor vascularity assessment also, people are using the ICG and all kind of things. Do you use it, or do you recommend to the people, those who are well versed with the technology and centers which are equipped with that? So what is your take on that intraoperative fluorescence navigation?
we are not using, so that it's not available
Okay,
with us.
that's good. Next, I'll move on to the techniques, like depending upon your size of the lesion. At times you have clearly shown that there is a use of multi-corridor approach or multiple minimal invasive approach are clubbed into the one case to get the best results out of that case. If at all you need to select two different corridors for the same lesion, do you do in the same sitting or you stage it? So it's very important for the people to understand, if you do it in the same sitting, what are your pros and cons, and if you stage it, on what basis you tend to stage the surgeries?
So you mean to ask endoscopic and transcranial approach altogether?
Yeah, because suppose if it is a large meningioma or a large craniopharyngium where it is crossing lateral to the carotid, which is not feasible to go through the transnasal corridor, you can take a transcranial as well as transcranial both at the same sitting, in the same case at least. So do you select both techniques to be done simultaneously by two different teams or single team operating one after other on the same sitting, or you stage the surgery for a next day or some other day later to do? Suppose you finish the transnasal approach, need to go for a transcranial, do you club both in the same sitting or you space the procedures?
No, most of the time, like we need to study the radiological images in the detail. There is one question also I can see, like how do we decide about endonasal and transcranial approach for the plenum and tubercular meningioma?
That's totally different, because that's totally different. What I'm saying is there's a particular tumor, suppose Knopfler or Goel-4 kind of giant pituitary tumor where you can't approach the tumor completely through the transnasal corridor. When you need to take up the transnasal corridor, when you need to go for stage that. Okay, that's good.
I saw one case like when we did endoscopic and transcranial both. So we would like.
We'll take one more question. There is a question from the audience. What are your take on the pediatric cases for transnasal approaches for arthroscopic surgery?
Yeah, Dr. Sharma, if you don't mind, I'm coming to that question also. We'll go step by step so that it will be good for the audience. So the next in line will be when you're doing the reconstruction procedures, Anil, usually is something like called 3F, like fat, flap, and flash. Flash means how early you mobilize the cases. Okay. Fat and flaps are very commonly known to most of the guys who are doing these procedures. Regarding the mobilization, how early you mobilize the patients out of your ICU, how early you discharge these cases of extended endonasal approach cases?
No, our when there is extended approach, like for meningioma, when there is CSF leak or craniopharyngioma, we need to discuss it separately. First, standard pituitary cases, when there is no CSF leak, we remove the pack on the third post-operative day. So there are different practices. Some people keep for 5 days, some keep for 7 days. But our standard practice is we remove the nasal pack on the third post-operative day and we mobilize the patient. and depending on the status of the diabetes insipidus and all those factors, we discharge the patient.
Okay.
And for yes.
Yeah, please carry on.
And when there is extension into the third ventricle, like third ventricle has been entered, there is a wide opening of the arachnoid. When there is cisternal disruption or cisternal dissection, in those cases, we like to put intraoperative lumbar drain that we keep for 3 to 5 days. 3 to 5
Good.
days,
Yeah.
and depending on CSF leak, then we remove that.
Very good. The other question, actually, already your discussion has started with that. Functional preservation approaches through the transnasal. I think your discussion started with that. I fully agree with you, the preservation of nasal mucosa as much as possible. Coming to the simple standard pituitaries, do you still like to go endonasal, or transeptal is also good for you to go ahead? Because I do a lot of transeptal approaches where the disruption of nasal mucosa is practically negligible, where go-in will be straight and then closer is also very much comfortable. And the mucosal damage is minimized to the least, actually. So there will be some amount of, sometimes if it is too much adhered because of the bony spicules or deviated septum, the mucosa may get a little bit torn on the process of elevating the septal mucosal flap. Do you have any experience on that, or if not, if based on your theoretical knowledge, do you recommend to the people?
We will do two surgeon forehand technique.
For all the cases?
All the cases.
Oh, that's okay. Okay. The last question is like specific approaches regarding to the pediatric cases and adult cases. So two surgeon forehand technique always will have some amount of nasal disruption, basically, which will lead to a lot of nasal complication like synechia, foul smelling, and all those things. Especially tender age groups, when you use the transnasal approaches, they will leave with some amount of nasal disability. So suppose a pediatric angioma comes in, even though it looks quite good to go through transnasal approaches, given the chance, do you prefer to take the transcranial like supraorbital? I do a lot of cases on that front. So except some specific indications are there, what is your take on either? You still prefer to go transnasal, or you can consider transcranial like maybe supraorbital or some mini pterional craniotomy could be easy enough to tackle these cases?
Look, for craniopharyngioma also, my indications are limited. When there is significant,
Okay.
like as we have seen in the discussion also, when there is significant extension into the cellar widening, and without calcification, and in few couple of cases there was sphenoidal extension also, as we have seen in the images. In pediatric cases, one more problem is there is conchal type of sphenoid sinus. So that is not
Exactly.
not a contraindication, but sometimes that drilling and all those things can be troublesome. So my indications for craniopharyngium are limited. So in those kind of cases, I prefer a transcranial approach, standard transcranial approach.
Good. Last comment, actually, last one. I found through of your videos, when you're using the upcut while going closer to the medial OCR and lateral corridors to most of the textbook teaching, or most of the seniors, what they recommend is you drill eggshell thin, and then whenever you use an upcut, you just pull it up, actually, rather than using a cut to the bone. Actually, many a times, especially old age people, the dura can be hardened and the medial portions of the carotid can get stuck into that, and it can cause the devastation. So just for the viewers, so better to drill and then just lift it up, like just like how you're doing with the dissector. So instead of cutting, you can just lift it up with the foot plate, actually, rather than using a cut punch, actually. So that's one small observation out of your videos. So otherwise,
you recommended to make that axle down. Make that thin. Without that thinning, it should not be removed.
Yeah. Thank you very much, Anil. It's excellent visual feast from your videos and your talk. I will hand over to the moderator to take it for the other questions.
There are a few questions from the audience, Anil. One question is regarding whether you have any experience of using CUSA endoscopically, and another one is how you are managing in the post-operative CSF if there is a CSF leak supposedly and you have not expected it. So do you routinely put a lumbar drain directly, or you take some time and go back, and how much, or you manage it with Dimox and bed rest?
Yeah,
I'd
QSA
I'd like to just remark one thing. That question was from Wai Ping. He's a neurosurgeon from Malaysia. Okay, sorry to
Yeah,
interrupt.
this,
Sorry to interrupt.
yeah. This is a question from Mr. Dr. Wiping from Malaysia.
QSA is required for like when there is fibrous tumor, like as we have seen that meningioma video, surgical video. So that tumor was quite fibrous. So in these kind of cases, QSA can be useful. But for
In
standard
fact,
pituitary pharyngioma, that cavitron ultrasonic aspirator is not required because these tumors are quite soft and easily suckable with the suction. Problem with QSA, like when we use QSA, so there is some amount of blurring of the visual field, where some amount of blurring and obscuration of vision while using endoscope. But it can be used when there is fibrous tumor. There is it's not coming with suction. Ultrasonic aspirator can be used. Second question, that CSF leak, as I think we have discussed that earlier. So if there is immediate postoperative period, there is CSF leak, it's advisable to re-explore and repair again. So it's better to re-explore and repair.
And I think this has been a very nice discussion overall. And I have a small comment to make with, because we have been in our centers operating a lot of cases, but though endoscoping in most of the pituitary now, it's a standard way of operating through transnasal routes. And we have recently starting doing this keyhole approaches, endoscopic approaches also. But somehow I feel for large tumors and for sometimes recurrent pituitary adenoma, you should always have a training for transcranial approaches. That should be the take-home message. And with the advancement, probably we will have days for 3D endoscopes and other things. And in recently, I would also like to make a small comment. We can use radio frequency ablation endoscopically if there are the tumor is very vascular. Thank you so much. If any other questions from the esteemed panelists, I think we make
Patient selection is very paramount in these kind of cases.
Yes.
We need to study anatomy in detail, radiology in detail, the patient related endoscopic skull base anatomy, radiological anatomy of the tumor, extent of the tumor, all those things we need to study in detail preoperatively. That is very paramount to dictate about the approach.
Over to
Yeah,
John.
good.
I think there's a couple of questions in the chat. Do you see them?
Yeah.
The Arman, I think there's a question.
There is one. There is one question. What is your if there is a unilateral IC encasement by the pituitary tumor, so can we still attempt by transnasal approach? And this is from Dr. Raghav Jinder, and another one is from Dr. D.M. Arman. What is your experience with the youngest patient for pediatric pharyngioma for endoscopic approaches? Anil.
I think 5 years. 5 years.
5 years.
And that as far as that IC encasement is considered, like for non-functioning pituitary, so that tumor can be resected, that the patient will there will be improvement in the visual outcome, and that some part, if non-functional tumor, it does not matter much. We need not to explore that ICA, and but in functional tumor, either we need to explore cavernous sinus and we may resect that, or we can give gamma knife for the residual tumor. There are two options.
Thank you very much, Anil. I think.
Thank you very much.
I think we
Okay.
can close the session, John.
Yeah, very good. No, I don't have a question, but thank you for having a very interactive session. And thank you for taking the time out of your busy schedule. We could do this a regular thing every 2 weeks if you want. You can think about it and talk about it. But to have a line to the AIIMS system is excellent, because as you know, it's some of the best in India, the best neurosurgery programs in India. So Okay. Thank you
Thank
very
you,
much,
Thank you,
everybody.
Jen.
Thank
Yeah.
Thank you. Thank
Good
you,
night,
John.
guys.
Thank
Thank you.
Bye, guys.
Thank you.